So some of the things that we'll be looking at is the RHC billing rules and identify some differences between non-RHC clinic settings and the rules you have with your RHC. In order to become certified as an RHC, there's many policies and procedures for conditions of participation, but today we're going to focus on the revenue cycle policies and procedures that you may be missing. I'll be sharing some of our thoughts on how to analyze your accounts receivable, and we'll review the billable versus non-billable services that are provided in the RHC setting. And we'll finish up then with some key performance indicators that you'll want to monitor as you strive for best practice benchmarks. So first, the RHC billing rules. Just some oversight things as a reminder. An RHC visit is a medically necessary face-to-face visit with an eligible provider. And since RHC services are billed on the UBO4 versus the CMS 1500 form with a place of service, we have to be aware of the revenue code that we're using because that identifies the location where the services are provided. So here's our examples of the 0521, which is what we see most common because that's a visit at the RHC, but also covered as an RHC visit is a home visit under 0522. If your providers are doing any nursing home rounds, it'd be a 0524 if that patient is in a Part A skilled nursing stay, which means that wherever they are residing, they are billing their room and board and other services to Medicare. If they've exhausted their benefits, or if they were not at that skilled level of care, then we would use the 0525 revenue code. If by chance in your geographic area you have a home health shortage, you may be designated as allowed to bill visiting nurse services. If so, that would be a 0527. But again, you have to be designated and enrolled that way with Medicare. A 0524, it's a visit at the scene of an accident, or the 0900, which would be our mental health visits. Once the patients met their deductible for the year, you're going to be paid based on your Medicare, for both Medicare and Medicaid claims, an all-inclusive rate, which we refer to as the AIR. And so once that patient's met their deductible, you can expect to receive 80% of whatever your established AIR is based on your most recent cost reporting period. And a exception to this would be when providing preventive services only, because in those instances, you would expect Medicare to pay 100% of your AIR since the deductible and coinsurance is waived. And rarely will you get more than one AIR for the same date of service in the RHC, because unless providing a medical and mental visit on the same day, which would result in 2 AIR being paid, or if you had 2 completely separate identifiable visits where the patient left and then returned to the RHC on the same date of service for an unrelated visit, such as having had an accident or an injury after leaving for their initial appointment. That would be the only time that we use modifier 25 or 59 on our claims, because that would result in 2 AIR payments if we did. And the other one would be when you have a medical visit and that welcome to Medicare on the same day. In that instance, you also would receive 2 AIR. So we recommend reviewing your EOBs to assure that you aren't getting paid for 2 AIRs when the documentation does not support that. Here's our eligible providers. I'm sure everyone is familiar with this. It's a physician, defined as a doctor of medicine, osteopathy, dental, podiatry, or optometry, nurse practitioner, physician assistant, certified nurse midwives, visiting nurse services to the homebound, again, only if you're designated to be able to allow that, the clinical psychologist and a clinical social worker. So there are 3 different types of RHC designations, which determines what your AIR rate is. If you are operating a freestanding RHC, you're going to be limited to an AIR of $84.70 for the year 2019. This is the same AIR limit you will see if you have an RHC, which is provider-based to a hospital with 50 or more beds. There's no limiting amount of the AIR assigned to a provider-based RHC when associated with a hospital of less than 50 beds. In this instance, because the AIR is based on a cost reporting of expenses, provider-based clinics will have a different rate by location of operation. So if you operate more than one provider-based RHC, you can expect a different AIR rate at each of them. There are some services that are paid on the fee schedule. As with many billing rules and regulations, there's always some exceptions to what these rules are. So RHCs can provide chronic care management services, which we bill under CPT code G0511, and you will be paid the national average blended rate of $67.03 for 2019. This rate is the average of those CPT codes 99490, 99487, and 99489, which non-RHCs will bill based on that one code is for the minimum of 20 minutes, more complex, over 60 minutes, those type of things. But in the RHC, you may have a different price set for each of those codes, but it needs to convert to a G0511 for the billing of chronic care management. And you do not append the CG to this code, even if it's the only service reported on your claim, because doing so will most likely cause an edit for your claim to go into a return to provider status and not be paid. Another such instance when it's paid at a fee schedule is when the providing services for telehealth originating site. This is again billed on your UB04 using revenue code 0780 and HCPCS code Q3014. And this claim pays at the national average rate of the Medicare physician fee schedule of $26.15 for 2019. And just remember that RHCs are not allowed to bill the professional services of any telehealth visits. The professional services are referred to as the distant site provider, and RHCs are not eligible to bill that because basically because there's no face-to-face visit with that provider. There's a new code RHCs are allowed to bill for effective January 1 of this year, and it's the virtual communication services, which again is paid based on the Medicare physician fee schedule, not the AIR rate. And this is defined as a medical discussion or remote evaluation between an eligible provider at the RHC and the patient using communications-based technology, which CMS defines as either audio-only real-time telephone interaction. In addition to, you may have synchronous two-way audio interactions that are enhanced with video or other kinds of data communication. This is one of those codes that is where the face-to-face requirement is waived. Basically, it's going to be communication between the eligible provider and the patient, which lasts at least 5 minutes for a patient that's been seen in the past 12 months. And the communication is not related to an RHC service, which was provided in the past 7 days, and it doesn't lead to an RHC visit within the next 24 hours or whenever your next available appointment would be. Whenever a code is based upon time, we recommend documenting it in the patient record. Perhaps your EHR has the ability to enter a start and stop time. That would be beneficial. But this service is also paid at the national average blended rate of the codes that are covered under it, which is the G2012, which is the communication technology-based service, and G2010, which is the remote evaluation services. So we're expecting that this should be reimbursed at approximately $13.70. Since this is a new code, we're not sure how the Medicare Advantage plans are going to reimburse for it. So we recommend contacting them for instruction because they may apply an office copay to it since it is an allowed visit. Patient responsibility for deductible and coinsurance. When calculating the patient deductible and coinsurance, remember that Medicare will reimburse you at 80% of the AIR, which is going to be the same for all your encounters. The difference comes in the amount that is due from the patient, which is going to be 20% of your charges. So this will be 20% of the charge you report on the line where you've rolled the non-preventive service charges into that one line where you put on the CG modifier. Because that modifier tells Medicare, here's the total of the charges where the deductible and coinsurance are due. And it should never include anything that's considered a preventive service where Medicare waives the deductible and coinsurance. Because we're at the beginning of the year, we get lots of questions from RHCs regarding how the Medicare Part B deductible is calculated. So here's a couple of examples. These calculations are confusing to billers, to the patients when they see their EOBs, and secondary insurance payers. It's not uncommon during the first part of the year to see takebacks on your remits, or to get a remit where there's actually a negative and it'll be withheld on a subsequent remittance advice that you get. So the 2019 Medicare Part B deductible is $185. So in example one, I'm saying that the patient owes a partial deductible. So your charge is $70, your all-inclusive rate in this example is $100, and the patient only owes $25 of that $185 deductible. So Medicare is going to pay you 80% of, it's going to look at, here's your all-inclusive rate, less the deductible. So that would be $75. And 80% of $75, Medicare is going to pay you, or Medicare would pay at $60. The patient coinsurance is going to be 20% of the $70 total charge, less the $25 deductible. So 70 minus the 25 is going to be 45. 20% of that is going to be $9. So if you take the deductible of 25, that will be patient due or secondary insurance. We'll just, for this instance, say patient payment. $25 deductible, coinsurance a 9. The patient's going to pay you 34. So our Medicare payment of 60 plus the patient's payment of 34 gives you a total of $94. So in this instance, you're going to have to post as a contractual gain because your charges were only $70. In example 2, we're going to have where the patient owes the entire amount as deductible. So our charge is $115, your all-inclusive rate is $95, and your patient is going to owe their deductible because they haven't met that $185 yet. So Medicare is going to apply that total charge of $115 to the deductible. Even though your AIR is only $95, they're going to apply the total charge. So the patient is going to be responsible for the $115 deductible or charge amount. So your reimbursement is going to come through as a negative $20 because the patient's going to be responsible for $115, and that will bring you to your charge amount. Influenza and pneumococcal injections. Another billing rule that's sometimes confusing comes with these when these are provided. Even if there's a medically necessary face-to-face visit with the eligible provider the same day, these are never billed on the UB04 for traditional Medicare claims. You must keep a log or have the ability to pull the data from your billing system if you enter the charge. And then this log has to include the date of service, patient name, and the patient's MBI or Medicare beneficiary identifier, which is what we refer to the new Medicare numbers. We used to call them HIC numbers. Keep in mind that this billing rule does not apply to those beneficiaries that have enrolled in a Medicare Advantage plan, as there's no cost report. You only report these on the cost report for the beneficiaries that remain on traditional Medicare. So you're going to want to contact your Medicare Advantage plans and see how they want it submitted. Often we see that they are submitted on a separate CMS 1500 claim form, even if you may be submitting a UB04 for the RHC visit for the same day, because that's the only way they can identify that it needs to be separately paid. So on this 1500 form, you'll want to include the vaccine CHUC code along with the administration code of G0008 for the flu vaccine, or the G0009 for the pneumo vaccine, and be sure that your diagnosis code is that Z23. Counting visits in the RHC is another area where it's often confusion on what constitutes a countable visit. Generally, one visit per day, per patient per day, even if you see multiple providers on the same day. So if you're paid one AIR, it's one visit. Exception would be those rare instances where there's 2 visits when the patient physically leaves and returns on the same day for an unrelated service. So think back to those different revenue codes that are used to identify the place of service. Not only will you count the visits in the RHC clinic, but home visits and nursing facility visits are also counted. And these visits are going to be compared to productivity standards that we'll discuss in a later webinar in the series. We recommend not waiting, that your revenue cycle staff determine how they're going to count these visits and be gathering that data so that at the time that it's requested, we're already prepared for it. So we have to create a process for logging it either daily, weekly, monthly. Some RHCs are able to use your scheduling system. We want to be careful with that, as you may end up including no-shows or visits that weren't a medically necessary billable face-to-face visit, or were maybe rather a nurse-only visit. And then know that CMS has said that when we're billing that virtual communication service under the G0071, this is counted as an RHC visit. And just for your reference, we have provided an example for the visit counts here that you may want to incorporate into your practice so that you're capturing that along the way.
And the first polling question is true or false? Deductibles owed will be calculated as 100% of the charges up to the AIR.
Okay. This is actually false. The deductible is up to the charge amount, which might be more than what your AIR is. And Medicare will withhold monies from your payment since you're being paid more than what they would allow based on your individual all-inclusive rate. Next, we're going to move into, there's some RHC specific policies and procedures that are listed in Appendix G of manual, and those cover the overall clinic operations. But here we're going to be just talking about policies and procedures specific to your RHC process. We want to look at some steps to be taken to assure compliance and consistency in your billing process, tie together that whole registration process with charge capture for billing, and then following the regulations with attention to whatever your financial reporting requirements may be for your cost reporting. Oftentimes we find limited staff in our RHCs where there's little or no cross-training taking place, and it's important to have policies and procedures in place to keep the practice running in the event a staff member is unexpectedly might have an extended absence from work. So in the absence of policies and procedures for your clinic, you can expect to experience variations, when we don't have standardization, non-compliance with the rules and regulations, and we don't have the ability to hold staff accountable, and billing may stop. So where do we start? Oftentimes we find that staff are following some handwritten notes which have been passed down from biller to biller during training without a clear understanding of why we push the buttons we do or follow the actions being taken, other than to say, this is what I've been told. So it's important that staff understand the reason behind the task being performed. Not only does it build on their skill set, but it allows them to notice when something has changed or doesn't look right, and helps us be compliant. Medicare bad debt, there's often some questions on this. Medicare bad debt is the unpaid deductible and coinsurance after Medicare has paid, with no likelihood of being collectible in the future. The effort to collect these amounts must be similar to efforts put forth to collect comparable amounts from non-Medicare patients or non-Medicare payers. It includes issuance of a bill or statement upon discharge or death of the beneficiary to maybe an estate or the financially responsible party. It must involve the same statements, collection letters, phone calls, and use of an outside agency for all payers. Where a collection agency is used, Medicare expects the provider to refer all uncollected deductibles and coinsurance patient charges of like amounts to the agency without regard to that primary payer. And CMS has clarified that debts referred to a collection agency are not considered uncollectible and may not be reimbursed in the cost report until the bad debt is returned from the collection agency is uncollectible. If after a reasonable and customary attempts to collect, the debt remains unpaid more than 120 days from the date the first bill is mailed to the beneficiary, it may be deemed uncollectible. So just be aware also that if you receive any payments on an account that's been classified as bad debt, that 120-day period will restart. If you have a small balance write-off policy, these amounts are an administrative adjustment, and you can't report those as bad debt either. When a Medicare beneficiary is duly enrolled with Medicare and Medicaid, and your state's Medicaid doesn't pay the full amount of the deductible and the co-insurance amounts reported on the Medicare EOB, basically saying the primary paid more than they would allow, you can claim that difference as Medicare bad debt at the time that you have the EOB in front of you. So it's reported in the year that it's identified as uncollectible by completing Exhibit 2 of the cost report. So again, revenue cycle staff need to be prepared to supply this information to finance upon request for the cost report. There's often confusion regarding what is a contractual write-off and what is an adjustment. It's important to have policies and procedures which clearly defines what adjustments are. Contractual is the amount to be written off as reported on the remittance advice as charges that are more than the allowable amount per your contracts. Adjustments are other balances which are left on accounts without regard to the required contractual write-offs. These are administrative adjustments such as small balance write-off, untimely filing, provider not enrolled, medical necessity, late charges, Medicare bad debt, again, the ability to run that report so that we can report it. You want to have processes in place where there's a segregation of duties, whereas the person responsible for billing and claim adjudication doesn't also make adjustments to accounts, because without having a process where identified adjustments are logged, approved by a manager, and posted by another staff member, your clinic is at risk of missed payment opportunities for denied services. It's most likely not intentional, but all non-paid services should be reviewed to get to the root cause, correct the issue, or identify if it is indeed a non-covered service that the patient would be responsible for. And here we've just included an example of a log you might want to incorporate. It can be printed off, completed, and given to the person who's responsible for posting. It allows you a mechanism for quantifying the adjustments, where you've got a different log, maybe based on the different denial reasons that we just covered. Another area where we often need policies and procedures is in regards to secondary claims. They're challenging because of the different claim forms required. For example, you might be filing a secondary on a CMS 1500 claim right now with a place of service 11. However, you should be reporting a 72, which is designated as rural health clinic. We recommend always using that when submitting a secondary claim where Medicare was primary, because this may help the payer understand that the Medicare EOB is going to reflect a different payment methodology versus what they're used to seeing for regular Medicare Part B line item remits. Regardless of how the primary claim is submitted, when Medicare is a secondary payer, you must submit it according to the Medicare rules. So it has to be on the UB04. You have to apply the revenue codes that are appropriate. And if you have a claim where the primary insurance pays for things that are non-RHC services, such as nurse-only visits or labs that you might have filed to the primary, you have to be aware that you're going to have to pull those off of that claim and identify what portion of the payment is for an RHC service, or in the case of nurse-only visits, you're going to have to administratively adjust, because if it's not reportable to Medicare's primary, it's not reportable when they're secondary. So you want to have policies and procedures addressing how to separate charges and payments between different types of claims if the primary insurance includes that billable E&M and service not billed out of the RHC when Medicare is secondary. Not only should your policy address Medicare as when Medicare is the primary payer and you're sending to another, but also when Medicare is a secondary payer. So again, you may have differences. You follow those billing rules for whoever that payer is. A few slides ago, we talked about that confusion over those negative payments when applying deductible up to that total charge. So that's going to carry over to these secondaries. Oftentimes it takes a phone call to get them to understand how it needs to be processed.
What is an example of Medicare bad debt?
Okay, yep, both 1 and 2. It has to be returned from the collection agency and reported in the year that it is deemed uncollectible. Having to make an administrative adjustment due to untimely filing or not appealing a denial on a Medicare claim is a staff procedural issue, and it's not reportable as bad debt. So now we're going to look at some ways to analyze your accounts receivable and assign tasks for timely adjudication of claims. Here's some steps. Take a look at your AR summary by payer and identify the areas where an aging bucket is out of the desired range. You want to not only do this at month end, but determine what you want to monitor daily. For example, you may be monitoring charges, cash payments daily, but maybe claim submissions is on a weekly basis. And you're going to want to compare those findings from week to week or month to month so that you can identify trends quickly, develop an action plan. Don't run an entire outstanding balance at the beginning of the month when staff can't possibly get through all of them. As later in the month, they may be also running across accounts that were paid, have been paid by this time. So really, whenever possible and staffing allows, we recommend doing an alpha split so that billers are cross-trained as opposed to having payer-specific assignments so that they can cover for each other. And focus your follow-up on a manageable amount of accounts to work. And once that's completed, have staff move into another group of accounts to review. This helps staff feel like they're accountable or that like they're accomplishing something as opposed to becoming overwhelmed. We recommend meeting bi-weekly, so every 2 weeks with staff on any balance that is outstanding that is over 90 days so that you be sure that we're staying on top of those. So those summary buckets, financial class, you're probably going to have buckets under unbilled 0 to 30, over 60. Run these reports by date of service, not when they were last billed, because you may run into untimely filing, and run it without the credit balances included, because oftentimes when we're reviewing this and we look at it, we've got credit balances, which might not be money owed back to patients or an insurance carrier, but maybe a contractual posting error. We'll find those in there, which isn't giving us a true picture of accounts that are, let's say, over 90 days, because those credit balances are in there as well. You want to focus on timely filing limits, those credit balances. Be sure that you know what your state's unclaimed property rules are. We can't just leave credit balances sitting on books forever. We have a responsibility to return those monies to the rightful owner. Establish high dollar amounts you want to look at. Be sure that any unapplied payments, if your system, let's say you're collecting co-pays at this kind of service, if you have unapplied payments, be sure that those get applied before you're running and looking at these reports. So here's some system issues that may be affecting your accounts receivable. Bill hold days. It's not typically something that clinics have because you're generally entering charges and dropping a bill. However, if you hospitals often do this so that they can be sure that all their different departments get their charges in before a claim is billed. So be aware, if you're owned by a hospital and using their billing system, claims may not be dropping the next day after charges are entered. And this slows the billing process and is going to increase the AR days specific to clinic. If we're not getting all the correct demographic information at the time of scheduling or registration, or charges that are missed on the initial claim requiring a rebill, actions being taken which affect the account but not documented in note. Example, document pre-auths, insurance verification data. Any calls between the patient or the guarantor should be documented. Be sure to document if you're sending paper claims or records, because all of these things can help you in the case that you may have a timely filing issue. Training is huge. For the revenue cycle positions of registrar, billing, coding, we recommend that when you bring those people on board or move them into those positions, that they spend a couple days shadowing coworkers in each of these areas, because in order to gain an understanding of the entire process and just how each step or action affects another area of the revenue cycle process, they have to be exposed to it. Look for tools that are available to streamline or automate processes. Be sure that staff have access to payer portals to correct or adjust claims, verifying insurance, eligibility screens, or maybe in the common working file in DDE, they'll tell you when a Medicare beneficiary is eligible for a preventive service. Also lets you know if the patient is opted out of traditional Medicare, is enrolled in a Medicare Advantage plan, or is in a hospice election period. All of these types of things may slow down your process. And be sure to explore all your options for establishing work queues in your billing system. Have a call with your vendor and see if there are options available in an update that you weren't aware of. And challenge them for assistance in identifying and monitoring denials, follow-up of accounts, registration errors, coding edits. And then, of course, be sure that staff are not sharing user IDs and passwords, because that's a huge compliance issue. One way to keep an account with the errors from aging is to set up edits in either your billing system or your clearinghouse to catch previously aired claims prior to submission. So once you become aware of one of those root causes of something, set edits to assure things like there's no symbols or punctuation in the patient name and address. Set alerts for revenue and CPT code combinations that may be wrong. Modifiers, work with your coding staff, in case there's edits where you should be charging bilateral service, such as an ear lavage or Jordan injections, to determine is 2 units billed or 2 lines with one having a modifier to indicate it's separately identifiable. Those type of things, look at that. Set alerts for medical necessity to assure that the diagnosis covers the CPT codes being billed. This isn't an issue with E&M services, however, with procedures or labs. And frequency here, again, I'm referring to when is the patient next due for preventive type services. So best case scenario for the patient's financial journey is that the services rendered follow a path which really kind of lays that foundation on the front end to meet the patient's expectations by discussing payment options in the case of a financial hardship. Share with them whenever we run eligibility and we know that there's a deductible, copay, coinsurance, and collect those up front whenever possible. Not just the collector, the billing staff needs to know what the options are, but discuss it at monthly clinic meetings with your providers and other clinic staff so that if a patient inquires with them on charges or concern with being able to pay, know who they need to talk to prior to leaving that clinic. So we keep sending the same message to the patient. Monitor accounts to turn to patient responsibility at the time of final payment. Sometimes we see accounts that are hung up in insurance pending because maybe there was a coordination of benefits between two payers, but it was never turned to patient responsibility for remaining coinsurance or copays due. Establish your policies and procedures for prompt pay discounts, small amounts write-off, monthly payment plans, etc., on anything that's left as a payment responsible amount. Automate as much of the process as possible, and be sure to list who to contact in the case of billing questions on your website, letters, statements, anywhere that the patient may be accessing that information. So let's talk about statements a little bit. Are we processing them internally or have we outsourced them? Do we send them once a month or on a weekly basis? We recommend establishing a cycle by an alpha split to send statements so as to spread the workload out over the course of a month and keep your cash kind of flowing that way as well. A great collection tool is having a prompt pay discount for monies paid at the time of service or maybe within 15 days of receiving a statement. So look at those options. Negotiating for uninsured or underinsured payments. Do we have a policy for discussing a discount for prompt payment? Having policies and procedures, really empowers the staff to be able to work with that patient in gaining that patient trust because they see that we're trying to work with them. Don't just put it out there as a marketing tool or post it on your website. Patients have to believe that we're really working with the staff. And all of it is education and the continued giving out the same information all the time. And we previously talked about minimum statement balances, but work through the process and establish a policy for each patient encounter balance. Are you doing it, or identify if you want to do it for each patient encounter, or if you want to look at it as a family balance. Take into consideration your state's Medicaid copay, oftentimes wanting to set it lower than that amount so that the efforts continue to collect copays as you are required. Dig deep into your denial management and establish a plan to resolve information found. 90% of all denials are preventable. About 2/3 of those are recoverable. And some payers don't allow adjustments to claim anymore. So you would lose that opportunity to recover that. So preventing denials is always better for your bottom line than reprocessing claims to obtain the reimbursement due because of the cost associated and the resources that it takes to do that. Another report that should be monitored bi-weekly is the credit balance report. What is the reason of the credit balances? Do we have posting errors due to issues with electronic remittance advice postings? And that sometimes happens when a claim is submitted under one claim number and paid, And then another, because of the payer rules, if we have to have some late charges and we're filing an adjusted claim. Sometimes the remittance advice is confusing on the contractual amount when payers are both paying a portion of the claim. You know, you got to pull those EOBs, determine who's the primary payer and amount that should be posted for each contractual. When there's coordination of benefits, you know, occasionally a family may have both the father and mother carrying insurance coverage, and there is no real coordination of benefits like we see with primary and secondary claims. And so they both pay as primary. You know, what is our policy going to be? How are we going to handle those? Do we have a credit because the patient's health insurance and a liability insurance paid? You know, we have to refund the health insurance. And then overpayments may be due to true overpayments that need to be refunded to the patient or another payer. We typically recommend adjusting the claim or canceling a claim to get that payment for payers taken back on a remittance advice, because it gives you a good trail as opposed to having to issue a check and send that. And have a process to transfer the outstanding self-pay accounts prior to refunding. You know, you've got an issue if you were to refund one family member while sending a statement on another family member's account. Do we share contract information with the revenue cycle staff? What is the expected reimbursement for a payer, or timely filing limits that you'll find in your contracts, timeliness of adjusted claims, and how they should follow up with that? Is there an interactive voice response unit? Is there websites? Do you go to payer portals? These things all lead to revenue cycle leakage, draining your margins. Payers are tightening their reimbursement due to their need to be compliant with reform requirements and looking for every opportunity to get out of paying a claim. They're able to do this through creating tougher negotiations by paying you less when not part of a larger preferred provider group, passing on complex contract terms in relations to timely filing, pre-authorizations, appeal processes. I'm sure that you've all experienced kind of that increased denial rate associated with all these complex contract terms. And be it intentional or unintentional, we see carriers underpaying providers based on what their negotiated rates. This is especially true in rural areas where a contract may allow for additional reimbursement due to negotiations you have in place because you are a rural healthcare designated provider. And oftentimes they're overlooked. They seem insignificant at first, but it can really build. The advisory board company estimates losses for the average facility to be at 5% of its annual revenue. So best practice organizations are making gains by optimizing your contract negotiations whenever possible. Don't underestimate the ability to recover underpayments from carriers. Sometimes it's as easy as placing a call and having a claim reprocessed. But run those reimbursement reports for a specific payer. Look to be sure that you're getting paid that percentage or the fee schedule amount that you're supposed to be. Are you getting your per day AIR fixed rate for your RHC, Medicare, Medicare Advantage, and Medicaid claims? And when you identify there's a denied service versus a non-covered service, have a process in place to identify the next steps. Non-covered in their policy maybe can be billed to the patient. Denied because we billed incorrectly or codes don't support services provided will require follow-up. That includes those things like where a procedure may be a part of another, or number of units is incorrect, maybe when billing your J codes for pharmacy items. And some services are just statutorily excluded from payer payment, and the patient owes that. So just be aware of what those things are.
True or false? 90% of all denials are preventable.
Yep, that's true. You know, in the RHC setting, typically the errors are related to missing or incomplete registration information, not things that are related to, you know, coding issues, because we don't do a lot of that type of billing. So we're going to talk about billable versus non-billable. In order to bill for services, we have to capture those charges. So one of the things is that, you know, that charge capture and recording of information used for claim creation includes charge posting and reconciliation of the medical service that we provided. So that documentation is key. When we think about missed charges, what are those type of things that we would expect are there but are not there? And are the quantities billed appropriate? What are the number of units billed that are going to match with the code description that we're billing for? Remember that non-Medicare and Medicaid payers are not subject to the same rules for RHC billing. So you're going to be maintaining charges which are billable to non-Medicare and Medicaids on your CMS 1500 forms, such as nurse-only visits. Unlike non-rural health clinics, you have to who must combine all their services provided for the same practice or specialty on your RHC encounter, we may see where you have a Medicare RHC visit because the RHC is paid by practice versus the provider. You could also bill a hospital admission on that same date of service. So you might have a UB for your RHC and a 1500 for your hospital. Global Medicare global billing rules differ for RHCs from other payers. OB claims per visit for the antepartum and postpartum, and then delivery only for the hospital service. So you can bill for all those antepartum and postpartum visits in your RHC and get your AIR rate, as long as when you bill for the delivery, either your provider or another provider, they have to be sure that they bill it as the delivery only fee. Same thing with surgery. If your surgeon, whoever's doing the surgery, bills with the 54 modifier, where they're going to get a 20% reduction of the Medicare physician fee schedule for the procedure because it included the surgery follow-up, then as long as you can verify that that's happening, you can bill each of those follow-up visits in the RHC as long as it's a face-to-face visit with the provider. And then, or if you have two visit notes and are documented in there, those are some of the things that you may have a work comp claim, but you may also have a Medicare claim or on the same date of service. Remember that there are ancillary services that are not covered in the RHC, such as lab, radiology, and the technical component of the EKG. The venipuncture remains on the RHC claim, but these services, if you're in a freestanding clinic, will be billed on the CMS 1500 with the RHC NPI. If you're a provider-based RHC, it'll be billed by the hospital on the UB with that entity's NPI. And the EKG billing is never billed globally under the 93000. The 93005 is considered the technical portion that's going to be billed to Medicare Part B, either on the 1500 or by your hospital. And then the professional component can be billed by the RHC if the provider interprets and documents the report on the same day that there was that face-to-face visit. We've talked about RHC claims and charges that are submitted to Medicare Part A, but you're also going to have some professional charges, or you may also have some professional charges which are billed to Medicare Part B because they're non-RHC services. So these are things provided outside of the wall of the RHC besides those nursing facility and patient home. And so clinicians and groups fall under the low volume threshold and are exempt from MIPS if you bill less than $90,000 worth of Medicare Part B allowable charges in a year, provide covered professional services for 20 or fewer Part B enrolled individuals, or provide 20 or fewer covered professional services for Part B enrolled individuals. So you wouldn't expect to be seeing those reductions. The dates have changed from previous years. So now they use data from the dates, these dates to determine the eligibility. So it was October 1st through September 30 of 2019 is our most current reporting period. Pharmacists are not qualified RHC providers as their services become a billable, they can't be a billable encounter. And we see a lot of some increase in the pharmacists providing some medication therapy management, which is billable to Medicare and other settings, but it's not a standalone billable service in the RHC. But these services could be provided as part of your CCM program. That includes the DSMT and the MNT, those where your registered dietitian is meeting with the patient. That could be under your CCM, but it is not billable out of the RHC. And nurse-only visits in other locations are billable, but not in your RHC. Medicare Part B covered immunizations. Medicare only covers the flu, pneumo, and immunizations of tetanus on the same day as a face-to-face with the medical necessity, such as an accident or an injury, not just for the prophylactic immunization just because 10 years have passed. In this instance, the patient can be billed for the tetanus and administration fee, or usually they can obtain it at a county nurse office, so just know what those options are. And the hepatitis B is covered for patients with a covered diagnosis, which puts them at risk. So that could be included on your claim. on the same day as face-to-face visit. All others, such as like the shingles vaccine, they're covered under Medicare Part D. And so know your options, where the pharmacy can file for their Medicare coverage under their Part D. They can bill and administer it. If the patient receives it in the RHC and they are financially, then they would be financially responsible. You would want to, once they've paid, give them a receipt and an itemized bill so that they can bill it to their PharmD by themselves. Or there are things out there like the TransRx, whereas you can get into an agreement with a pharmacy where they will get that vaccine, run it through the patient's PharmD, and then ship it to you or provide it to you for you to administer to the patient. Now we're going to look at some opportunities to assist you, in your financial success by looking at your benchmarking. If you've participated in any of our other webinars that we had, some healthcare webinars last fall, you've seen this diagram before. So I've included again just to remind us of all the processes that are involved along the way when working with the revenue cycle. It starts with patient access and customer expectations, or kind of that revenue cycle front end, the importance of gathering accurate data up front. And the front end is responsible for gathering 50% of the information that is required for mapping of that data directly to your claim for the billing process. We call the midsection, that includes kind of your charge capture, the creation of charges for services, whatever's documented in the patient record. And you've got to be constantly monitoring compliance with patient requirements in there. Leading organizations identified as high performing best practice optimize the use of the technology whenever possible. And then that revenue cycle back-end process covers what happens once charges have been captured, the encounter coded, released, so that billing, following all of the regulations. Important to this, is that you should consider, or not consider, you should conduct a ChargeMaster maintenance at least on a yearly basis for your regulatory updates and any HCPCS and ICD-10 coding changes for revenue reliability, because then you must update your billing system, keeping in mind that there are payer-specific changes which may need to be made. And talking about pricing, do you have contracts that are paying a percent of charges that limit the amount of yearly price increases? For example, 3% increase, and so you're getting paid 80% of charges and you're limited to 3%. Well, if you charge a 5%, then your reimbursement rate is probably going to be reduced by that 2% increase because you went over that 3%. Look for, are you paid the lesser of charges or a fee schedule? So, be sure that your charges are at least set above. So an example of this would be if you're providing chronic care management, because the national average blended rate for reimbursement is $67.03, you want to be sure that you don't have a chronic care management charge set at less than $67.03, or you're going to be reimbursed that lesser of, which would be your rate if it's below that $67.03. And if you do the telehealth originating site, be sure that your price is above that $26.15. Charge capture responsibility falls to a lot of people, but the eligible provider is responsible for documenting what was provided. Nursing staff also have to add things such as charges for supplies, injectables, that documentation is there and the charge is there. Then you look at coding, CPT, ICD-10 assignment, that the record supports all the charges that are on the claim, that all the results from ordered tests are there prior to that billing process. So just being sure that they're all accounted for, services are charged appropriately and compliantly, and that charges are entered into the appropriate system and then billed accurately and timely. Some billing issues, we've kind of gone over these. The missed charges is a missed revenue opportunity. Payment denials or delays all these things increase that workload for the back end when you're reworking claims or have to do a charge reconciliation, which increases your accounts receivable, results in poor customer satisfaction ratings due to inaccurate bills, and it increases your potential for Medicare scrutiny when they request information you are found to be consistently non-compliant, there is the possibility of penalties for that. And then that contract negotiations impact on your practice. There are internal edits and things that should be set up so that you can capture things prior to billing the claim so that they aren't being billed incorrectly. Is it your internal billing software edits, clearinghouse edits? Someone should be monitoring and look at your transmission reports. Compare it to your system generated claim count. So you're going to get out of your billing system an 837 file, which is going to say all these were the number and quantity of claims that were transmitted. The 999 acknowledges the insurance received them, and the 277 is going to be we accepted them. Sometimes claims are rejected at the front end. You will never get a denial. It will appear as if the insurance didn't respond to your request, but it could be because it's in that file. And we should always be working rejected claims within 24 hours. So here we've included some RHC benchmarks, because if you don't measure it, you can't manage it. And what you want to do is start out and see where are we now and how far do we have to go. It's not a one size fits all. So these are just some indicators that you may want to be monitoring.
True or false, a successful revenue cycle is an easy process which involves many different areas of your organization requiring little interaction.
Okay, yeah, it's obviously false. Each provider employee of the RHC is responsible for documenting the services provided while assuring correct payer is going to be billed. And that's the only way you're going to accurately capture charges and collect payment for the services that are provided. Okay, Amy, do you have questions that came in?
We do. The first one says, do the CCM visits count as an RHC visit?
They do not. Because there's no face-to-face required with those, and ancillary staff can be providing those services, they do not. And we will, I know on one of our other webinars in the series, they're going to talk about the reimbursement of that and how you carve out those expenses.
Okay. Can you go over the guidelines when and if an RHC can bill for a lab and pharmacy services?
So pharmacy services, if they are provided in conjunction or on the same day as a medically necessary face-to-face visit, you will put it on your claim. So if there's a J code that's associated with it, you're going to use a revenue code 636 and put on that HCPCS code. If there is not one, you will put it under revenue code 250, and you will roll that charge up into your line with your procedure or your E&M visit, and where it's on that CG line, because you will be able to collect 20% of the co-insurance on that. The labs are never billable in the RHC, even if it is the 6 required labs. They still, because all lab expenses are carved out of the cost report, so you don't get credit in your all-inclusive rate. So you want to bill for those separately. And again, either it'll be billed by your RHC on the CMS 1500 for Medicare fee schedule reimbursement, or it'll be billed by your parent hospital, and they will bill it on their claim.
Okay, we have time for just a few more. Regarding the Medicare RHC visit and hospital admission on the same date of service, is this only if 2 different providers doing the RHC visit and admission?
It is not. They are separate and unique. So if your provider sees a patient in your RHC and you can bill that as an RHC visit, and the decision is made to send them over to the hospital, and you're going to admit them as observation or as an inpatient, the thing that you have to be sure is that you have 2 separate records. It can't be a matter of the patient comes in and you very quickly move them over there. There has to be an identifiable service provided in the RHC prior to doing that. So sometimes when it's the same provider, you really don't have 2 separate records, because you can't use the information gathered in the clinic as part of your H&P. It kind of has to be separate in that setting, if that makes sense.
Okay. Are RHC required to have a sliding fee reschedule for payment, schedule for self-pay patients?
They,
And if
they
so, oh, sorry.
yep.
And if so, what are the requirements?
Yeah, no, you do not have to have one. FQHCs do have to have a sliding fee scale. RHCs are not required to have one. And so that just gets built into your policies and procedures. Do you offer financial assistance? Is this something that, you want to explore and have available, but you're not required to do so?
Okay, one more. How do you advise billing for an RHC covered service and a non-RHC covered service during the same visit?
Okay, so if we have, so I'm going to use an example of we see a patient and they have a billable visit. We have a medically necessary face-to-face visit. We're going to have an E&M code, and on this day, part of the discussion is the patient would like to receive the shingles vaccine, and that is not an RHC covered service. You can go ahead and put it on your claim. If you are providing, which we would recommend, that you present the patient with an ABN saying, we believe that this is not going to be covered because we know it's statutorily excluded. You're not required to do it on things that are statutorily excluded, but sometimes there's confusion for patients because they receive information saying, you're covered for this. Well, they're covered under Part D, not Part B, under their Farm D plan. So we would recommend giving them an ABN, and in that instance, you can add the GY modifier and put it into the non-covered column, but we would still submit it on your claim. Do not roll those charges into leave those on their own line. Do not roll it into your CG line, because if it's a non-covered service and we've identified that, we don't want the patient to be responsible for 20%. What that should do is on your EOB then, and when the patient receives it, it will tell them, we paid this amount and this is the amount that you are financially responsible for.
Okay, so a couple of people are asking about recordings. Yes, recording will be available. It does take us about 7 to 10 days to edit the video. And once we have that, we will send it out to our marketing team and they will send it to our participants. So give us about a week or so to get that out to you. You'll see it in your email. Dion, we do have about 5 more questions. Do you want me just to email them to you and you can contact these people individually, or do you want to go over them now?
I guess I'm okay with going over them. What might be, you'll have the questions. So maybe what we'll want to do is let's put them together and then we can send them out. Does
Okay.
that work?
Yep.
Okay.
That sounds great.
That way everyone can participate if they weren't able to stay online.
Right. Take a picture of that. Okay. So it says for non-RHC profit providers, you mentioned that we can bill to MCR Part B on CMS 1500. What about, or excuse me, what MPI is used?
Okay, so say that again, that first part.
For non-RHC profit services, you mentioned that we can bill to the MCR Part B on the
Oh,
CMS.
okay, so what I was referring to that there is oftentimes the same providers that are providing in our RHC also may be covering emergency room visits or seeing their patients at the hospital. Or they may do procedures over at the hospital. In those instances, those are non-RHC services, so we're going to bill them on the CMS 1500 form. Their time while they're doing that, when we looked at that log, there was, it wants you to account for hospital time as well, so non-RHC time, so that expense isn't put on your cost report. In those instances, you're going to be billing to Medicare Part B, and wherever your group is designated. If you are a freestanding RHC and you are billing those professional services out of your RHC, it's going to be your same RHC NPI number. Sometimes, if you're provider-based, under your RHC provider number, you may not bill any non-RHC professional services, and in that instance, your hospital may bill it under their NPI number. So it just really depends on how your group was established.
The next one says, can you go over why that first polling question was false?
Deductibles will be calculated at 100% of charges up to the all-inclusive rate, and that's false because they will apply deductible up to your total charges, not what your AIR is. So if your total charges are $120, but your AIR is only 100, and normally you would get paid based on that 100, they're going to apply it up to the 120 because they're going to go to the total charges. If your charges are over $185, then they would only apply up to $185 to the deductible. It is very confusing. There is no doubt on that. If you have any specific things that you would like to, just contact me and we'll talk about how you might want to fax some examples, and then we can have a phone conversation about what you're seeing on what your total charges are and what your remittance advices are looking like, because it is confusing.
Okay. The next one here, regarding the 25 and 59 modifier, would they also be used for a procedure or injection performed during a face-to-face visit regarding different issues?
Nope, they are not. And this is where it's also, unfortunately, because CMS opted to, with RHCs, when we started reporting all the line item detail, and they talked about when you would get paid for 2 visits and when you would not. I wish they would have come up with a different modifier, because with all other payers, when we have a separately identifiable service, which in this instance would be like an E&M and an injection fee or a venipuncture, we put the 25 on the E&M. For RHCs, when you do that, you are telling Medicare this patient left and returned the same day for a completely different reason. And what I recommend to clients is, because you have the option of using a 25 or a 59, and coding staff might not be stopping, especially if you've got hospital coders, they're coding your things for you. They're going to append that 25 because that's what they've been instructed to do. And that's what the coding rules are, that you append that 25. They don't, it would be unrealistic for us to ask them to stop and look to see, is this Medicare or non-Medicare, before appending their modifiers. So I tell clients, only ever on an RHC claim, instruct them when coding RHC claims, only ever use the 59, because if billers see a 25, they could then strip it off. But if we tell them for RHC only, whenever it is truly a separately billable visit where the patient left and returned, use 59s, then we could let those go through our billing system. But I know there are clients who automatically are having 25 stripped off in their clearinghouse on type of bill 711 for RHC services. But if it's a 59, they do let it go through. So those are just kind of some words of wisdom, I guess.
Okay, we're going to take time to answer these 3 and then we'll let everyone go on their way. In your first year as an RHC, how do the number of patients on your Medicaid panel affect your interim payment rate?
Yeah, that we're going to save that question and have it be covered, because I know it's going to be covered in one of the other webinars where they're actually going to be talking about cost reporting and finance and GLs and how rates are set and those type of things. So we'll save that question for them, because that is not my area of expertise.
No worries. Okay. When or should a swing bed visit be billed on a 1500 to Medicare B?
If it is performed by an RHC provider, it should not be, because it is, you can count it as a visit and you can get paid your all-inclusive rate, just as if the patient was in a nursing facility.
Okay, and then this one says, is a $3 copay considered a small balance? It would meet the criteria, but is it a copay we would like to claim as bad debt?
Yeah, so you cannot claim it as bad debt if you write it, if it meets your small balance write-off policy. That's why I alluded to the fact that you may want your small balance write-off policy to be less than that. However, sending out statements for $3 makes no sense. If we're not able to collect those copays at the time of service, they probably are going to become a small balance write-off and cannot be, unless you want to go through all the collection actions to collect it, you'd have to wait the 120 days. You'd have to, send it to your outside collection agency, everything that you would do for anybody else that had that balance. It's not going to be something that's going to be able to be reported as a bad debt.
All right. Well, that is all the questions.
Awesome.
All right. If you guys would like more information on our upcoming conferences, please just visit eidbailey.com. We will get this recording out to you as soon as possible. If you do have any more questions, go ahead and reach out to Dion, and we'll see you guys on the next one. Thank you, everyone. Have a good day.